minutes before we break, I'm going to talk a little bit about what I call the curious case of medical malpractice. And I call my talk the curious case of medical malpractice because, while the issue of malpractice receives a lot of attention intermittently, usually around election time, it's really hard to know how it relates to this issue we're talking about today. There's the medical view, okay? I think we all know what doctors think about malpractice. You can just say the words, or not malpractice, but at least malpractice law, right? And it's not just the AMA, it's physicians widely revile the medical malpractice law, and they blame it not only for making their own lives miserable and for high liability insurance premiums. They also claim that medical malpractice law worsens the quality of health care, that it is inimical to good care. Even the Institute of Medicine, I think, agrees. The famous report that To Err is Human, which we've heard reference to today, suggested that malpractice law stands in the way of hospitals undertaking the kind of patient safety efforts that we talked about today. And Deb's comments about the apology law suggest, right, doctors are afraid, they claim, to do the things that patients want, or in this case apologize, but they'll more say doctors can't look and discover errors and learn what they need to learn to prevent errors because of malpractice law. And that's widely claimed. The Institute of Medicine and doctors will also claim that the fear of malpractice leads to what is known as defensive medicine. They order more tests, they do more biopsies, they do more C-sections because they fear malpractice law. And to the extent that they are ordering procedures and doing things that are not clinically advised, right? That's bad care, even if nothing goes wrong. But of course, sometimes those extra C-sections, those extra biopsies lead themselves to adverse outcomes. And so that's bad care. Lawyers, of course, have a different point of view, right? From the perspective of lawyers and legal academics, one person's defense of medicine is another person's injury prevention. Lawyers and legal academics have traditionally argued that malpractice law imposes a cost on physicians for injurious practices, and that by doing so, it disincentivizes bad care. Or to put it in another way, fewer double negatives here, right? It creates an economic incentive to practice carefully. Lawyers also say that this works not only on the level of the individual provider, but also on the level of provider organization or enterprise, right? So that if hospitals can be liable for what's going on inside their walls, right, they will undertake efforts. Maybe they'll work with them. They'll have risk management. They'll try to figure out what's going on that is injurious because that will cost their bottom line. And if they're not liable, well, then, you know, they may have to worry about bad publicity. There are other ways to incentivize them, but the bottom line is a useful one, okay? Lawyers will also say that malpractice provides a forum for patients. Not all patients are going to go up on YouTube and be able to tell their story as eloquently as we just saw. Malpractice provides a way for patients to tell their story, and it also provides an incentive, right, it provides a way of going to court, getting the records, finding out what's really going on. Because otherwise hospitals may cover up a lot of things. And of course, malpractice law provides compensation for injured patients, right? Jeannie has lifelong injuries. Not everyone can afford it. Well, to think about what is the effect then, who's right? The doctors, the lawyers, right? It's bit about when is a medical injury malpractice? Well, a medical injury is malpractice only when it's caused by negligence. And most adverse events are not negligence, they're not malpractice. Lots of bad things happen in hospitals. Lots of times they happen in hospitals. They're not preventable. It's just really sick people get really sick, and bad things happen to really sick people. And really sick people can have procedures that we know just can't work all the time. That's not malpractice. Not even all preventable injuries are malpractice. In order for there to be malpractice, the injured patient must show that the physician, and I'm using physician here, but it could be the nurse, it could be the dentist, whatever, failed to conform to the generally recognized and standard practices of the profession. Okay? So the physician, in a sense, had to not do what is generally done, or had to do something that is not generally done by other practitioners. It's a practitioner-based standard of care. In addition, injured patients have to show that that act of malpractice was the legal cause of the injury, right? And sometimes actually, of course, for very sick patients, it's going to be very hard to do that because the underlying disease process itself could be the cause of the injury, or it could be so complicated trying to figure out what was caused by the error and what was caused by the disease. Well, what is the cost of malpractice litigation, malpractice law? Michelle Mello from the Harvard School of Health and her colleagues estimated that there was about $55.6 billion was spent on everything relating to malpractice in 2008. It's a very big number. A lot more money than, we'll ever see, but it's only actually 2.4% of total healthcare spending. On the other hand, the administrative costs that were estimated to be associated with malpractice claims, it's the administrative costs, the lawyer's fees, the court costs, the expert testimony, all that, it was not trivial. About $52,521 per claim. That's not a trivial amount of money. The transaction costs are high. Another way to look at the cost of malpractice is to think about the various ways there are, the various kinds of costs. And it showed, in this study, and this is from additional work by Michelle Mello and her colleagues, shows that the greatest contributor to the cost of malpractice is so-called defensive medicine. Okay? Despite the high transaction costs, they estimate, this makes a lot of sense because defensive medicine affects the broad population, not only claims filed, of course. So that the cost of defensive medicine in dollars may be quite high. And they estimated about $45.5 billion. It's not chump change. I didn't mean to do that. Oh no. Sorry, I hit the wrong button. Okay. The critical question, I think, for today's conversation, and today's class, and this isn't the class on healthcare costs, it's the class on quality and patient safety, is does malpractice deter medical errors? And the short answer is we don't know. And before preparing today, I once again did a lot of reading, look at the latest studies. The answer is we just actually don't know. Okay, we know there's defensive medicine. We think. And I'll get to that in a minute. But we don't actually know, right, whether we have more or fewer injuries because of malpractice law. We do know a couple things. We know that the vast majority of cases of malpractice don't lead to litigation. Most people who are injured due to medical errors that experts would say constituted malpractice, failed to comport with the physician-based standard of care, most people don't sue. We know that litigation has declined, actually significantly since 1995. Talking a little bit about some of the reasons. There's been a lot of empirical litigation about malpractice, empirical studies about malpractice law, but most of them have looked at the link between the law, and changed the law a little bit, and has it affect legal filings? Or how does it affect insurance premiums for doctors? Not how does it affect health care outcomes, right? We used to think, and there were some studies back in the 80s showing that there was this huge mismatch between malpractice, litigation, and claims, and cases of malpractice. So the famous Harvard medical study showed enormous numbers of cases of malpractice don't go to litigation, but they also suggested that most litigation has nothing to do with malpractice. And if that's right, then you think malpractice wouldn't have a lot to do with actually deterrent care, because this is really bad match between the two. Some more recent studies, and this is data from a study by David Studdard and colleagues, show that the mismatch may not be as bad as we once thought. Most individuals who were not actually injured don't receive any payment, but 63% of injured claimants actually were subject to medical error, and when there's error, 73% receive some compensation, suggesting that the malpractice litigation signal has got some decent signaling going on between bad practice and good practice. They also found that 72% of the cases in which their experts said there was no error didn't receive payment, suggesting that the court system is not, not terrible, not perfect, but not terrible at figuring out good cases and bad cases. We know that so-called assurance behavior, that's the extra ordering of tests and all that stuff, is pretty common, okay? But so is avoiding certain cases, supposedly because of the fear of medical malpractice. A survey said that 42% of high-risk specialists stated that they limited their practice and avoided certain procedures and avoided certain patients. On the other hand, it's hard to know if everything that doctors say they're doing because of malpractice law is really about malpractice law, right? It's hard to know that there's a lot of reason to believe that doctors will attribute some of their behavior to malpractice law when it's really not about malpractice law. For example, giving patients extra tests in a fee-for-service system is also often economically in the doctor's own self-interest, right? You don't want to say, I'm ordering this extra test because it's helping my paycheck. You might want to say, it's the lawyers who are making me do this. I don't want to send you for that one more test, but it's those lawyers, okay? And they may even believe it, but it's also good for their own economic interest. Hard to know, right? Same thing about risk, treating high-risk patients. Are you doing it because you're avoiding it because of the fear of malpractice, or are doctors avoiding them because those are painful and difficult cases, and nobody really wants to have bad outcomes, right? I mean, so, we are complicated beings, we human beings, and we have multiple motivations. And many of the motivations, and many of the behaviors that are attributed to malpractice law are often behaviors that are also, let's just say, multifactorial. There's another thing going on, which is doctors will often blame something on malpractice law, but maybe what they're doing, or what we more precisely should be saying, is they're attributing their behavior to their perception of malpractice law, not to the reality of malpractice law. And as a lawyer, I will say I all the time hear doctors, friends, relatives, my own practitioners tell me the law tells them to do something that the law does not tell them to do, right? But I don't think that's disingenuous, right? In other words, they're hearing it, they're fearing it, right? But it doesn't mean actually. So one thing we know is that the perceptions of the law may be more powerful as behavioral motivators than the actuality of the law. And maybe it doesn't matter what the law really is, it's what people think the law is. But it's hard to know. It's also really hard to know, right, how many many of those extra tests? So we could say, doctors say X percentage of extra tests are because of malpractice, but some of those extra tests probably do save lives or find things, right? And so again, how do we actually tease out and know to the extent that physicians are altering their behavior because of the law of malpractice or because of what they think the law of malpractice is? You know, how do we know, is it good or bad, right? What are the costs and benefits, not just in health insurance, but in dollars? And it turns out we just really don't know that. Last thing I want to say, and I said a moment ago that tort claims have gone down significantly since 1995. A lot of that may have to do with the fact that our states have enacted a lot of laws making it really, really hard to bring malpractice litigation. In some states, it's almost virtually impossible to bring a malpractice claim. 23 states have imposed statutory limits on non-economic damages. That's pain and suffering mostly we're talking about. These are damage caps. Of all of these so-called tort reforms that are up here, and I'll just talk very quickly about a few of them, this is the only one that has been shown empirically to actually have an impact in reducing litigation. This is the big one, the damage caps. It probably does reduce litigation. Doesn't mean it improves healthcare quality, but it probably does reduce litigation. Lawyers don't want to take cases with cap damages. On the other hand, understand what this is doing. Because damage caps, for example, saying you can't get more than $250,000 in pain and suffering, if somebody has a $200,000 claim, they have an injury, it's significant, but it's not as devastating as Ginny's, that cap has no applicability, right? They're under the cap. This cap only applies to the worst cases. This cap only stops the litigation of the people worst off. In that sense, it's a very regressive law. The 23 states have had. Several have struck it down. 6 state courts have struck these down, but it's existing in a lot of states. Many states, 36 states, have these doctor apology immunity laws. Okay. 28 states limit lawyers' fees. These are supposedly designed to lower the transaction costs and leave more money for claimants, and they may do it. Of course, they also dry up the litigation. 47 states require some kind of peer review expert panel to pass on the case, or at least to review the case before it goes to litigation. This sounds great, and there are a lot of positive things to be said about it. It increases the transaction costs substantially. It's one of the reasons transaction costs are so high now. The other are sort of more legalistic and more technical, but they are designed in various different ways to limit the payout from providers who are found negligent to patients, putting more of the money on other actors or on health insurance companies. That's what joint and several liability and the modified collateral source rule do. So malpractice, we've been doing a lot around the country, not at the national level, but at the state level, to limit malpractice law, and we are seeing the litigation fall pretty dramatically. On the other hand, whether that's allowing these patient safety efforts to go forward and improving health care, or whether that's taking away some of the incentives and making it harder for Deb and Dom to do what they do, to succeed in doing what they do, the truth is, we don't know. Thank you.